Good evening, everyone. At the outset, I should thank all the office bearers of WIMS Anesthesia Alumni Association, especially Professor Balbhaskar sir, Professor Sriramulu sir, Jyotsna madam, and Parimala madam, and also Dr. Sutish Kannan for chairing this session. So I have no conflict of interest or no financial support. So my lecture objective is to highlight the topic starting with few case scenarios. I'm not going there is no plan to go in detail about the case discussions, but just take few scenarios which we may encounter in our day-to-day practice, and the consequences of epidural hematoma and the anticoagulant pharmacology which is relevant to anesthesia practice, and about the from the recent guidelines. I have taken some abstracts from the recent guidelines, which is 2025 ASRA guidelines published this month, 2 weeks back exactly. So imagine a scenario wherein an 80-year-old female with fractured neck of femur, which was sustained 4 days back, and she was not on any medications, had an uneventful surgery under combined spinal epidural. But unfortunately, 24 hours after procedure, she develops shortness of breath, chest pain, cough, and becomes unconsciousness. She soon had profound BP fall, and echo showed dilated RV with the thrombus in the IVC, SVC, RARV. And in another scenario, you have a 76-year-old female with a history of AF, hypertension, stroke 2 months back, and she's now on warfarin for elective hip replacement. And obviously, patient has got high thrombotic risk, and warfarin was stopped 5 days back and now bridged with low molecular weight heparin, which is a therapeutic dose, high dose. And the last dose was 24 hours before, as per the protocol. In another situation, a 30-year-old primee with PIH, and the anesthesiologist is called for labor analgesia, and she is on prophylactic low molecular weight heparin and low dose aspirin. So what to do? And in another case, a 24-year-old patient with cardiac sarcoidosis, LV clot, LA clot, and with a severe PH, RARV, and with a dilated RARV dilatation with AF and global LV dysfunction on azithromycin 1 milligram OD, and is posted for obstructed inguinal hernia repair. So how to proceed? In another situation, 42-year-old male presented with ACS had a loading dose of Brillianta and unfortunately develops acute abdomen. There is gastric perforation, and patient is now posted for diagnostic laparoscopy or laparotomy. So what is worrying for anesthesiologist in all these scenarios, other than the perioperative bleeding, is that can we use a central neuraxial blockage as a sole anesthetic in certain situations, or in combination with general anesthesia to supplement analgesia? So what is worrying us is the possible development of spinal epidural haematoma. Actually, the bleeding most commonly is from the plexus in the epidural space. Rarely it can be in the subarachnoid or subdural space. And it can even happen in the subarachnoid space also. And the CNB is a central neuraxial blockage should not be attempted in patients who receive more than one antithrombotic medications. You have to be very, very, very careful. What about the difference between spinal epidural space? Basically, is that epidural, we know that it's a space between spinal dura and periosteum, and is richly supplied by venous plexus. And the area around the spinal cord is fixed, and any possible bleeding or enlargement of the space may compress on the nerve roots, spinal roots, causing neurological deficit. But bleeding, on the other hand, bleeding into the intrathecal space, especially a minor bleach, can usually diluted by CSF and can be less devastating than an epidural bleach. So what are the risk factors for the development of spinal epidural haematoma? A difficult or traumatic needle placement, any concomitant vascular abnormalities, hematological disorders like drug-induced coagulopathy, preeclamptic patients, patients with spinal abnormality or osteoporotics, wherein you have a difficult needle placement. Epidural catheter insertion, again, is more riskier than single shot techniques. And patients with the chronic kidney disease, especially because the action of these drugs is prolonged, and medications which can alter hemostasis, like some of the Ayurvedic medications, which the pharmacology we don't know, but there can be a concomitant anticoagulant activity also. Now we have to know the early warning signs or red flags like low back pain, which is described by the patient as sharp and radiating, with sensory and motor deficit after the and the deficit can occur. Sensory motor deficit can last after the expected duration of the block, and patient can develop even bowel or bladder symptoms. And paraplegia, of course, is a late presentation. And it's always important to interrupt or interfere in time space between the hematoma formation, because the time space between the hematoma formation and the surgical decompression is very important. That decides the prognosis. And it has to be treated in 8 to 12 hours of onset of symptoms. And emergency decompression craniotomy has to be, patient has to undergo for emergency decompression and hematoma evacuation. And the prognosis, I'm afraid, is generally very poor. What's the recorded incidence? As per Triba et al., published in 1993, it involves 20 case series from 1.5 million patients. The incidence is 1 in 1,50,000 for epidural and 1 in 2,20,000 for spinal. And the incidence could be even 10 times higher in patients on anticoagulants or when they have a traumatic puncture. But unfortunately, in this series, no further attempt was made to delineate the added risk due to anticoagulation, difficult central neuraxial blockage, of timing of catheter insertion or removal. Pharmacology is always relevant, means boring, but we should know some relevant pharmacology related to these agents. Because once upon a time, there was only two countries had nuclear weapons, and there were only two anticoagulants to worry about. Things have drastically changed in 2025, and now we have an n number of agents, and most of the drugs are coming into the market on a daily basis also. So unfractionated heparin enhances the antithrombin's ability to neutralize the thrombin, that is factor 2A, and activates factor 10A. It basically it prevents the fibrin formation and inhibits thrombin-induced activation of platelets. And the half-life with IV preparation is 60 to 90 minutes. And the activity may be monitored by measuring the activated partial thromboplastin time. Or if you're using large doses, go by the ACT. Unfractionated heparin, if in subcutaneous route, has got a maximum effect in 40 to 50 minutes, and it can last for 3 to 4 hours. And the activated partial thromboplastin time may remain in normal range. So it is a poor monitor of subcutaneous heparin activity. It's basically used for the prevention, treatment of acute thrombotic events and anticoagulations for dialysis and CPB, cardiopulmonary bypass. And the possibility of heparin-induced thrombocytopenia has to be remembered, especially in 30% patients with prolonged use. And you have to monitor the activated APTT, ACT, and anti-factor 10A activity. So check the platelet count if the patient is on heparin for 4 days, and interrupt heparin after 1 hour of block placement is generally safe. And central neuraxial block and the catheter removal 4 to 6 hours after the last dose and 1 hour prior to the next dose. And normal APTT should be documented before procedure, and the effects increases disproportionately with increasing dose. So nowadays, lower molecular weight heparin is preferred because of ease of administration. And most of the studies have shown that almost all the agents has the equal efficacy against venous thromboembolism prophylaxis. And enoxaparin and dalteparin is the common agents which we encounter in clinical practice. And the half-life is around 3 to 5 times more than unfractionated heparins, and anti-factor 10A activity is present 12 hours after injection. And long half-life allows once or twice daily injection. And anti-factor 10A measurements do not predict bleeding risk. And it has advantages that it has got less incidence of heparin-induced thrombocytopenia. So if you have a patient with on unfractionated heparin, discontinue heparin infusion 4 to 6 hours at least before central neuraxial blockage, and assess the coagulant status before blocking central neuraxial blockage. And if the patient is on low molecular weight heparin, it can be either a prophylactic dose or a therapeutic dose. If it is in a prophylactic dose, discontinue 12 hours before central neuraxial blockade. And if it is a prophylactic dose, 24 hours before the block. And the first dose should be given no sooner than 4 hours after catheter removal. And the fundoparinox is a selective inhibitor of factor 10A, and it has got a reversible binding to antithrombin. The bioavailability is 100%, and it has got a low risk of heparin-induced thrombocytopenia. And the half-life is 17 to 21 hours. And the ASRA, American Society of Regional Anesthesia, is against the use in presence of epidural catheter because we don't have concrete evidence to predict the safety of the agent. But if the patient is already on fundoparinox, it is better to go for a single shot rather than catheter technique. Prothrombin time and APTT are not suitable monitors of fundoparinox activity, and you have to go by fundoparinox specific anti-factor 10A activity assay. And suppose the patient is on CKD and the creatinine clearance is low, it is better avoided using fundoparinox. Now you have a newer oral anticoagulants, direct acting oral anticoagulants like dabigatran, which is reversible thrombin inhibitors, or factor 10A inhibitors like rivaroxaban, apixaban, and doxaban. The advantage is rapid onset and short elimination half-life, and no need for pre-op bridging, and has got a specific enzyme action and low risk of side effects, and has got predictable anticoagulant effects. And you need it has got a simplified protocol for discontinuation and resumption of treatment, and monitoring of anticoagulation is not required, but high individual variability in plasma levels is a cause of concern. So the protocol is depending on the creatinine clearance. For a low bleeding risk or high bleeding risk, it is applicable to surgical procedures, but you can extrapolate to a central neuraxial blockade also these protocols. Coming to the pharmacokinetics of direct oral anticoagulants, dabigatran, which is a prodrug, remember that it has got a poor bioavailability and renal elimination is very high and a longer duration of action. But when you come to rivaroxaban and apixaban, endoxaban, which is direct factor 10A inhibitors, they are got better bioavailability, but renal elimination varies from 75% to rivaroxaban to 25% apixaban. And the duration of action is always almost similar between these three agents. So what's the protocol when you are using a central neuraxial blockage? If you're using high dose apixaban, the protocol is to discontinue 72 hours before, for a low dose 36 hours before, and rivaroxaban 72 hours before, and for a low dose 24 hours before, and dabigatran again discontinue for 72 hours if you're a high dose, and for a low dose, discontinue 48 hours before. So always remember that it is acceptable to perform neuraxial anesthesia or catheter removal if the residual direct oral anticoagulant specific antibody factor 10A level is less than 30 nanogram per ml, which shows a lack of detectable anticoagulant effect, but unfortunately do not guarantee safety of neuraxial anesthesia. You have to again be precautious, take all precautions like avoid multiple attempts or avoid in a patients with anticipated difficult spinals or epidural. Warfarin is a commonly used drug which has got a narrow therapeutic window, but the problem is its long duration of action, like 2 to 5 days. And the dose we know is always adjusted depending on the INR values monitoring. And there is a need for preoperative bridging therapy if you plan surgical procedures for central neuraxial blockade for these patients. And always remember the drug induction agents, concomitant use of drug interactions with agents which can induce cytochrome 450. And patients on warfarin need dietary restrictions with the foods containing vitamin K. What about emergency reversal? If bleeding risk is minor and non-urgent, you can use vitamin K 10 units IV, or in emergency and serious bleeding, you can go by 10 units vitamin K along with prothrombin complex concentrate over 1 hour. If PCC is not available, you can use fresh frozen plasma. And in trauma patients, the evidence is in favor of tranexamic acid 1 gram, and can be repeated every 8 hours. And the PCC, prothrombin complex dose, has to be adjusted depending on the INR values. Platelet P2Y12 receptor block is now commonly used. Clopidogrel is the commonest drug which most of us encounter in our day-to-day practice. And the protocol says that it has to be stopped 5 to 7 days before the attempting central neuraxial blockage. Whereas for prasugrel and ticagrelin, you have to stop it for at least 10 days before central neuraxial blockage. Brillianta, ticagrelol, which is another commonly used drugs, you need at least 5 days interval. And what about giving a loading dose or non-loading dose after procedure, central neuraxial blockage? Loading dose you can give safely 6 hours after central neuraxial blockage, and non-loading dose can be immediately after catheter removal or attempting central neuraxial blockage. What about a new molecule? Any new molecule coming to the practice and there is no definite protocol in place, it is better to go by the at least 2 drug half-lives between the last dose of the drug and performance of neuraxial anesthesia, because it guarantees low level of anticoagulant in the blood. But the better conservative approach is to wait for 5 elimination half-lives, which means that 97% elimination of the drug. The points to remember is that if you have a concurrent use of 2 anticoagulants or coagulation altering medications, the risk of bleeding is high. And the epidural opioids or dilute local anesthetics allow early diagnosis of a neurological deficit in case of a difficult epidural placement. And the removal of the catheter is best when the epidural anticoagulant activities is low. And you have to always time the next dose after catheter removal as per the protocol. And frequent neurological assessment should be there for early detection of epidural haematoma. And high risk cases, you need to have a high risk of suspicion and continue monitoring of neurological status for 24 hours post catheter removal. For emergency removal, you can use for low molecular weight heparin, protamine maximum is 50 milligram, but efficacy is very low, approximately 60% only. Unfractionated heparin, you can give better efficacy if you are using protamine 1 milligram for 100 ml, 100 international units. Apixaban, you have a definite antidote, recombinant human factor 10A, and dabigatran, you have monoclonal antibody as antidote. So there are some debatable issues like whether the surgery should be postponed in the event of a bloody puncture and an intraoperative or postoperative anticoagulation is planned. You can always discuss the scenario with your professional colleague, surgeon, and you can always take the patient and the other bystanders into the decision-making loop, and you can always assess the risk and benefits before proceeding or canceling the case. If you are proceeding with the surgery, you have to go by the intense neurosensory monitoring in the postoperative period. And the catheter is removed 4 hours after the last dose of IV heparin and at least 1 hour before the next dose. Another issue is can we have central neuraxial blockade in obstetric patients who are already on antithrombotic medications? The consensus is that you have to always weigh the risk of possible spinal epidural haematoma against the risk of GA, which is much higher in obstetric patients. So it is better to switch from low molecular weight heparin to unfractionated heparin, which has got a lower half-life. Or if the patient is already on unfractionated heparin, reduce the dose of unfractionated heparin near the end of pregnancy. So to conclude, ASRA guidelines, go by the ASRA guidelines 2025, which has come out 2 weeks back. You can always go through that. Know the pharmacology of the agent before you put it into clinical practice. And always have the habit of monitoring sensory and motor functions in all patients, especially patients, not only in patients on antiplatelets or anticoagulants, but also in patients whom you had a difficult epidural placement. And frequent checks at least 2 hours for every 60 hours if you have a new anticoagulant regimen in place. And epidural use always the smallest effective concentration of the local anesthetic. Thank you for your patient listening.